Welcome to Clinical Minute. Martina is a 17-year-old Guatemalan-American cisgender female who is in her senior year of high school and will be graduating soon. She presents to the school-based health center with complaints of vaginal itching and increased vaginal discharge. She is visibly upset, saying, "I don't know what's going on, but whatever it is, it's freaking me out." Martina is 5 feet 5 inches, 130 pounds, and reports no alcohol or tobacco use, other substance use, medications, or chronic health conditions. Per her health record, she's never had any sexually transmitted infections, or STIs, and has never been pregnant. When you ask about her menstrual history, Martina says she had her first period at age 14 and has had regular periods since. Her last menstrual period started 2 weeks ago. You go on to tell Martina that you'd like to ask her some questions about her sexual history and practices. You say, "I understand that these questions are personal, but they are important for your overall health. And just so you know, I ask these questions to all my teen and adult patients, regardless of age, gender, or relationship status. These questions are as important as the questions about other areas of your physical and mental health. Like the rest of our visits, this information is kept in strict confidence. Do you have any questions before we get started?" Martina says that she doesn't have any questions. It is common for providers to skip at least some parts of the sexual history unless a patient has signs or symptoms of STIs. Even then, assumptions may be made about behaviors and corresponding risk status for pregnancy and infection. Learning about patients' sexual history and practices is an important part of providing appropriate care and gives opportunities to educate and counsel patients about pregnancy and STIs, and to determine tests or vaccinations that may be needed. Some providers prefer to start the conversation about patients' sexual histories with an open-ended request for information, such as, "Tell me about your sexual activity," or "Tell me about your sexual partners over the last year." Other providers prefer to use a model developed by the Centers for Disease Control and Prevention, or CDC, called the 5 Ps: partners, practices, past history of STIs, protection from STIs, and pregnancy plans. You begin with the questions about partners. In response to these questions, Martina states that she has had a total of 3 lifetime sexual partners: 1 female partner for the last 3 months, another female in the past year, and 1 male more than a year ago. When asked these questions, Martina says she doesn't know of any past partners having sex with anyone else while they were together. She also says that she has no history of assault or abuse. Based on her initial answers, you go on to ask selected questions from the 5 Ps model. But first, you let her know that your questions are going to get a bit more explicit about the kind of sex she has had. You ask her about what types of sex she's had: vaginal, anal, or oral. Although Martina seems to understand what you're asking, you're always ready to define these terms if needed. For example, you sometimes need to explain to patients that oral sex means putting your mouth on someone's penis, vagina, or anus. In response to these questions, Martina says that she's given and received oral sex with both women and men and has had vaginal and anal sex with a man. She and her current female partner do not use any barrier protection. Because you remember that Martina indicated in her health record that she has no prior history of STIs, you do not question her further on this topic. Based on Martina's symptoms and sexual history, you tell her that you would like to do a visual exam and take a sample of her discharge to see what's going on. Also, you would recommend testing for chlamydia and gonorrhea. She agrees to the exam and testing. On exam, there are no visible warts or other lesions, and there is no evidence of cervicitis. Microscopy of her discharge is positive for fungal elements and negative for trichomoniasis and clue cells. The diagnosis is vulvovaginal candidiasis, more commonly known as a yeast infection. You give her the choice of treatment with oral fluconazole or miconazole nitrate vaginal cream. You are also thinking about Martina's risk for human papillomavirus, or HPV. You know that risk factors associated with HPV infection may be both biologically and behaviorally based. Biologically based risk factors primarily affect the oncogenesis pathway and include characteristics of the HPV virus itself and intrinsic host factors affecting immune response. Behaviorally based risk factors are linked to the acquisition of HPV infection. Both are logical factors to consider in risk-based HPV vaccination strategies. Given Martina's age, you know it's important to include HPV risk and risk reduction as part of your broad-based STI prevention conversation. You share with Martina that some of her risk factors for genital HPV include being young, under age 25, starting to have sex at an early age, 16 years or younger, having more than one sex partner, regardless of their gender, having a partner who has had more than one partner. You further counsel her that most individuals get HPV infections shortly after becoming sexually active, and that HPV can be transmitted through vaginal or anal receptive intercourse, non-penetrating sexual activities, including oral genital contact and skin-to-skin contact. In females, genital warts most often appear on the vulva, on the cervix, in or around the vagina, anus, mouth, or throat. Virtually all cases of cervical cancer are caused by HPV, and just 2 HPV types, 16 and 18, are responsible for about 70% of all cases. While women who primarily or exclusively have sex with women are at risk for infection with HPV, relatively little is still known about the prevalence of HPV infection among this population. Limited research suggests that, compared with heterosexual women, women who have sex with women may have higher rates of high-risk HPV infection and a greater prevalence of cervical cancer. Barriers to receiving adequate gynecologic care in this population are thought to be related primarily to lack of access to affordable, client-centered care. Obstacles include a variety of factors, including high cost of health care and lack of insurance, provider and staff bias, stigma, and lack of information on the part of providers as well as patients themselves. In addition, biological risk factors such as heavy smoking and alcohol may play a role. Importantly, healthcare providers may inaccurately assess the risk of HPV infection in lesbians and other sexual minority women, or SMWs. Regardless of a client's sexual orientation and gender identity, providers should offer and provide STI screening according to current national guidelines from the Centers for Disease Control and Prevention, or CDC, and the U.S. Preventive Services Task Force. HPV DNA prevalence was analyzed in cervicovaginal specimens of 1,363 females aged 14 through 19 during 3 years of the pre-vaccine era, from 2003 through 2006, and in 736 females during 4 years of the vaccine era, from 2009 through 2012. Prevalence of HPV types 6, 11, 16, and 18, the types sensitive to the quadrivalent vaccine, and other HPV types not affected by the quadrivalent vaccine, were compared between eras. Among females in this age group, there were statistically significant declines in quadrivalent HPV type prevalence, from 11.5% to 4.3%, as well as a statistically significant decline in prevalence of HPV 16 and 18, from 7.1% to 2.8% between the pre-vaccine and vaccine eras. Despite an impressive reduction in HPV prevalence following the introduction of HPV vaccines, many adolescents remain unvaccinated. Per CDC data, 4 out of 10 adolescent females and 6 out of 10 adolescent males have not yet received the HPV vaccine, leaving them vulnerable to HPV-related cancers. In the U.S., we continue to have significant racial, ethnic disparities in rates of HPV-related cancers and in mortality rates associated with these cancers. Although these cancers are typically slow-growing, it is crucial to note that disparities currently persist in rates of uptake of the vaccine. For example, while Black and Latina adolescent females have similar or even higher rates of initiating HPV vaccination than their white counterparts, studies show that Black females are less likely to complete the series compared with white females. Unfortunately, similar research data among male adolescents is not yet available. Several barriers have been identified that contribute to low HPV vaccination rates among adolescents, including parental, healthcare professional, and adolescent barriers. Some of these barriers include lack of recommendation from healthcare provider, lack of parental approval or consent, lack of awareness that vaccine can and should be given to males, preferences among adolescents for teen clinics. Vaccine may not be available. In some states, HPV immunization may not be included in confidential sexual health services for teens. During its February 2015 meeting, the Advisory Committee on Immunization Practices, or ACIP, recommended 9-valent HPV vaccine as one of 3 HPV vaccines that can be used for routine vaccination. Additionally, in October 2016, the Food and Drug Administration and ACIP approved a 2-dose regimen for 9-valent HPV for girls and boys 9 to 14 years of age. Compared with the 3-dose regimen in young women 16 to 26 years of age, the 2-dose regimen generates non-inferior anti-HPV 6, 11, 16, 18, 31, 33, 45, 52, and 58 antibody responses. The second dose is given at 6 or 12 months following the first dose, with a plus or minus 4-week window. When you ask Martina whether she or her partner has received the HPV vaccine, she replies that she is not sure. You counsel Martina that an HPV vaccine is available and is recommended for both males and females. It can be started at age 9 up through age 21 for males and age 26 for females. Martina indicates that she can ask her parents if they remember having her vaccinated for HPV when she was younger. She says that if her parents confirm she has not been vaccinated for HPV, she will come back to your clinic with her girlfriend and they can both start the vaccine series. Martina also says she will ensure she receives her second and third injections at the health center of the college she is starting in a few months, or with her high school's affiliated clinic when she returns home for winter break. She agrees it's probably a good idea to talk with her girlfriend about their historical risk for STIs, HPV, though she feels a little awkward about introducing the topic. You also ask Martina how she feels about negotiating condom use if she chooses to have sex with a male partner in the future. She says she's done so before and feels very confident. You tell Martina that she's welcome to call you with any questions that may come up and say goodbye.